The question is that this House do now adjourn. Olly Glover.
Thank you, Madam Deputy Speaker. In the United Kingdom, more than 600,000 people, 1 in 100, live with epilepsy, and every day around 80 people are diagnosed. Sudden unexpected death in epilepsy, abbreviated as SUDEP, is the term used when a person with epilepsy dies suddenly and unexpectedly. At least 21 people die every week in the UK from SUDEP, and even that is an underestimate, with epilepsy deaths believed to be under-recorded. There are two key themes I want to raise today in this debate. Firstly, the SUDEP and epilepsy risk communication and understanding gap. And secondly, the inherent systemic failure to prevent deaths following prevention of death reports. I will conclude by outlining my key asks which are needed for lasting and meaningful change. Epilepsy-related deaths range from prolonged seizures and accidents to drownings and suicide. However, SUDEP is a devastating worst outcome, accounting for half of all epilepsy fatalities. According to the charity SUDEP Action and the Epilepsy Research Institute, the highest rates of death are in areas of deprivation and among vulnerable groups, such as those with worsening mental health, people with learning disabilities or autism, pregnant women and children. SUDEP affects all ages, but we know that it disproportionately affects the young, with a peak in people's 20s and 30s. I happily give way to the Honourable Gentleman.
I'm really grateful for him giving way and for him bringing this debate tonight. I've been asked to come along on behalf of my constituent James Nichols, who lost a dear friend in just that age group to SUDEP and has been a tireless campaigner on this issue ever since. He explained to me that the really tragic thing about SUDEP is that it can often come somewhat out of the blue through breakthrough seizures after an individual has not had seizures for many years, which can make it a particularly traumatic experience for a loved one's family member. Could he perhaps just touch a bit more on this and what we can do to support family members?
I thank the Honourable Gentleman for his intervention, and I pay tribute to his constituent and their family. I'm going to be talking quite a lot about what we can do to prevent such occurrences in future as I go on.
On that point,
I give way to the Honourable Gentleman.
Madam Deputy Speaker, first of all, can I commend the Honourable Gentleman for did thought and wanted for bringing this forward. I spoke to him beforehand, and like the Honourable Gentleman in an intervention before, I'm here to represent my people in Northern Ireland and those who are affected by this. SUDEP affects 1 in 1,000 people with epilepsy annually, including many cases in Northern Ireland, and yet many families say that they are not aware of the dangers of these nighttime tonic-clonic seizures. So does the Honourable Member, when he looks forward to what we need to do government-wise, not agree that more must be done to educate patients, family members, to ensure that the information is known and that thereby precautions can take place? Thank you.
I thank the Honourable Gentleman for his intervention. He's absolutely correct to say that awareness raising and increasing understanding are key priorities in dealing with SUDEP and epilepsy in general. Patients with epilepsy carry a risk of premature death, which is on average 2 to 3 times higher than the general population, as outlined by Frontiers in Epidemiology. What is most devastating is the knowledge that 60% of epilepsy-related deaths are believed to be preventable each year, according to the European Journal of Neurology, with SUDEP accounting for many of these deaths.
The Honourable Gentleman give way.
I give way to the Honourable Gentleman.
And can I thank the Honourable Gentleman for giving way and for bringing this really essential debate. My constituent, Emma Taylor, tragically lost her daughter at the age of 19, and she now tirelessly campaigns for SUDEP Action as a policy champion. Does my honourable friend agree with her on the need for the government to promote proper first aid seizure training?
I thank the Honourable Gentleman for his intervention. I do very much agree with his constituent, and I thank her for her tireless campaigning and offer my condolences for her loss. My Oxfordshire constituency of Didcot and Wantage is the home to SUDEP Action, a charity that is local, national and international in its impact. In 1995, 5 bereaved women came together around a kitchen table to found the charity in tribute to Alan, aged 27, Matthew, 21, Natalie, 22 and William, 22. And all who had died unrecognised before. Jane Hannah, Sheila Pring, Catherine Brooks, Sue Kelk and Jennifer Preston faced despair together and chose to build hope. Since 2020, SUDEP Action has worked alongside the Epilepsy Research Institute to identify tackling epilepsy deaths as a #1 research priority. The key challenge which SUDEP Action is facing is the problem of research insight which does not reliably or quickly reach neurology consultations, primary care or social care. National Institute for Clinical Excellence guidelines exist, but services are inadequately supported to implement them. Jane Hannah from SUDEP Action told me that my own constituents face 9-month waits for a first seizure clinic and 9 to 12 months for follow-ups. She told me that waits of this magnitude, such as we are experiencing in my constituency, are unsafe. Her partner, Alan, waited 4 months and died suddenly 5 months later. Waits like these aren't just confined to my constituency, but are reflective of a structural problem across the country. Now, free safety tools exist to tackle lack of knowledge and complacency around seizures and SUDEP, but systemic issues are difficult to shift because of poor access, poor medicine management, failure to communicate risk, and poor recording of deaths. An independent review was named after Clive Treacy. Clive died at 47 in 2017 in a hospital setting where he had lived for 10 years. The report on his life is shocking for this country in the 21st century. Now, the Minister may be aware of the debate secured by the Honourable Member for Lichfield last year, who I'm very pleased to see in his place, and the response from the Parliamentary Under-Secretary of State for Health, Innovation and Safety, the Honourable Member for Glasgow South West, who supported the Clive Treacy checklist. I give way to the Honourable Gentleman.
Can I thank the Honourable Member for bringing to light the Clive Treacy checklist, because it is a really fitting way to remember Clive. I think what's really important, though, is to remember that although it's named after Clive, he's not defined by his epilepsy, he wasn't defined by his learning disability, but he doesn't need to be defined by his death. Clive was somebody who loved to paint, he was a really talented gardener, and I think his family are really eager that his real memory is those memories that they carry with him. So I do want to make sure I take the opportunity to put that on the record. One thing that's also very clear when you look into the Clive Treacy checklist is that SUDEP risk for people with learning disabilities and epilepsy is 3 times higher, so 300%, but the actual risk of SUDEP can be cut by 84% if people have got an annual checkup, and that's part of what the Clive Treacy checklist advises NHS trusts to follow. So can I again thank him for that and ask him to invite him to do all he can alongside me, and I'm sure many other members, to make sure that every single NHS trust introduces and follows that Clive Treacy checklist to protect some of the most vulnerable people in our societies.
I thank the Honourable Gentleman for his intervention and his tribute to his constituent, and I look forward to working with him and others on this issue in the future. This checklist, commissioned by NHS Midlands and developed by SUDEP Action, is designed for commissioners and providers of care. There is hope that it will be red flagged in annual health checks for people with learning disabilities, as the Honourable Gentleman has said. Despite this high-risk cohort, most families, like Clive's, were unaware of SUDEP and epilepsy risk, despite earlier learnings from deaths. They were never given the information they needed, and mistakes of the past continue to repeat themselves. Recent research by the European Journal of Neurology surveying neurologists found that only 1/5 discuss SUDEP with all patients. It speaks to an unacceptable systemic failure. More than 20 years after national guidance was introduced, young people and their families are still being left in the dark. So what needs to be done? SUDEP Action has developed practical safety tools to empower neighbourhoods. The SUDEP and seizure safety checklist, the Epsilon app, an app which helps to understand one's personal epilepsy risks, and the Charlie card, supporting risk reduction and communication across care settings. We know that where the adult checklist is used, SUDEP conversations have risen from 20% to 80% and risks have fallen. But the challenges are vast. Progress is fragmented, it's far too slow, and at a time of rising inequalities, all too often, the risks are getting worse. The series of prevention of death reports into epilepsy reflect broader patterns. Missed opportunities, a SUDEP and epilepsy risk communication gap, a failure to act, and a culture that too often fails to listen to families.
Will the Honourable Gentleman give way?
I give way to the Honourable Gentleman.
5 years ago, my constituent Nadine tragically lost her brother Trevor to epilepsy. An inquest into Trevor's death ruled that his healthcare team at the prison staff of the prison that he was in had not carried out their duties, which led directly to his death. Trevor's death, sadly, is one of many which outline a clear unresolved gap in epilepsy care in custodial settings. So does the Honourable Gentleman agree with me that the best way to prevent epilepsy deaths in prison is with education and training to ensure that no life is lost to epilepsy due to lack of awareness or understanding?
I thank the Honourable Gentleman for his intervention, and he's absolutely right to raise prison as another setting where people are often vulnerable, where more needs to be done in relation to SUDEP. Sepsis, with a similar history of systemic failure, will shortly benefit from a modern service framework co-produced with the Sepsis Trust. Meanwhile, neither epilepsy nor neurology is explicitly mentioned in the NHS 10-year plan. There is a mandatory national framework to protect unborn children from anti-seizure medication risks, but there is no mandatory national framework to protect people living with epilepsy from SUDEP and epilepsy deaths, despite 30 years of evidence and repeated calls for action. SUDEP Action provides intensive assistance on 60 to 70 investigations of deaths each year and sees the toll of long, drawn-out processes and far too often a defensive culture by default. It also sees a painful accountability gap where inquests are not even held and families feel silenced. Complacency around SUDEP seizures and epilepsy, first called out by Liam Donaldson as Chief Medical Officer in his annual report in 2021, carries wider harms for communities and persists in too many places. Moving towards my conclusion, Madam Deputy Speaker, I wish to outline some key asks for the Minister. Now, there are hundreds more stories from families that I wish I could have shared today, but I always endeavour to be as brief and concise as possible in this setting. My thoughts are with all in the bereaved community who I stand by and will continue to campaign for. In order to effectively support the wonderful charities that are doing so much to prevent SUDEP and support families through this, I put forward 4 questions to the Minister. Question 1. Will the Minister commit to developing a modern framework for SUDEP? This would require policymakers working on epilepsy to work with those with lived experience via SUDEP Action and spread good practice. With mandatory information on side effects from anti-seizure medicines, there must be a framework for person-centred information about SUDEP and seizure risk and national training initiatives that support whole system learning. Epilepsy and SUDEP must be included in neighbourhood health, integrated with acute hospitals, social care and community health settings, as well as prisons, as the Honourable Gentleman said, to maximise the opportunity for prevention. And there must be safe levels of epilepsy specialist doctors and nurses in local areas. Improving the quality of the annual check for learning disability to include a SUDEP check for people with epilepsy would be a significant step forward to upskill primary care. Question 2. Will the Minister today commit to arranging a meeting with SUDEP Action? Ministerial colleagues have offered engagement on prevention of death reports with the SUDEP Action charity, promising meetings in letters sent in January and February this year, but such meetings have yet to take place. Question 3. Will the Minister support a national oversight mechanism in the Hillsborough Bill? Families have been campaigning for an amendment to the Hillsborough law so that there can be a single permanent oversight body to prevent the same mistakes across different tragedies, such as Grenfell, Post Office, Horizon Scandal, Infected Blood and others. This would track progress across government departments and public authorities, publicly report on failures, delays or resistance to reform, and prevent repeated cycles of injustice seen after major disasters and scandals. Finally, will the Minister accept an invitation to visit my constituency to see the work of SUDEP Action, a charity built by families and clinical champions from grief, sustained by courage and determined to stop deaths? I'm grateful for the Minister's time in this adjournment debate and look forward to her response.
Minister Sharon Hodgson.
Thank you very much, Madam Deputy Speaker. And I would like to start by thanking the Honourable Member for Didcot and Wantage for securing this important debate. And at the outset, I will say I'm very happy to meet with him to discuss all the action points he raised at during the end of his speech, and where that meeting takes place we can discuss that also. Sudden unexpected death in epilepsy, or SUDEP for short, is a vitally important issue, not only for those directly and tragically affected, but also for many members too. And we must learn lessons when deaths occur and make the changes needed. We must also ensure timely access to the right specialist support for people with epilepsy, including tackling long waits for neurology appointments, and continue to build the evidence base so that innovative treatments such as medical cannabis, where clinically appropriate, are available in a safe and consistent way. And I will set out the actions we are taking with the NHS and partners to reduce risks as well as improve outcomes for people living with epilepsy. Firstly, there is a statutory duty for organisations to respond to prevention of future deaths report issued by a coroner when their investigation identifies circumstances that create a risk of future deaths. And this provides a clear mechanism for organisations to set out the actions they will take to address these risks. Alongside the PFD process, it's essential that the NHS also continues to strengthen how it identifies and acts to mitigate risk in day-to-day epilepsy care. And that is why we are working with the NHS and partners to embed structured risk assessments and consistent risk communication for epilepsy in routine practice, so that known risk factors are identified early, addressed where possible, and discussed openly with patients and families in line with best practice. And cutting waiting lists is a key priority for this government, including for neurology services. And we have committed to achieving the NHS constitutional standard that 92% of patients should wait no longer than 18 weeks from referral to treatment by March 29. And we've already delivered 5.2 million additional elective appointments in our first year in government. Waiting lists overall are coming down, but we recognise they remain too high, with neurology remaining a particularly challenged speciality. And for patients with epilepsy, timely access to specialist advice, supported by clear referral routes and coordinated care across primary care, community services and hospitals is critical to good outcomes. And nationally, NHS England's Neurology Transformation Programme developed a model of integrated care to support integrated care boards to deliver the right service at the right time to patients as close to home as possible. And for those with refractory epilepsy who need highly specialised input, NHS England's updated service specification for specialised adult neurology services is clear that specialised neurology centres must include services for the assessment and management of refractory epilepsy. Progress is being made on the treatment backlog, and between February 25 and February 26, the number of incomplete neurology pathways reduced by over 10,000. The average waiting time reduced from 16.5 to 15 weeks, and the proportion of patients seen within 18 weeks increased to 57.9%. And we will continue to work with the NHS to improve access and reduce delays for patients, including those with epilepsy and families. Research is central to improving outcomes for people with epilepsy, and the Department funds research into epilepsy through the National Institute for Health and Care Research, or NIHR. And in the 5 years from April 2020 to March 25, we committed almost £19 million to 15 epilepsy research projects. And the NIHR also welcomes applications on all topics, including epilepsy. And on medical cannabis, I fully understand why patients and families continue to press for safe and equitable access, particularly for children with drug-resistant epilepsy. And there is one licensed cannabis-based medicine, Epidiolex, which is available for prescribing on the NHS where clinically appropriate, following clear evidence of its safety and clinical and cost effectiveness. Most cannabis-based medicines that patients are seeking are unlicensed and have not been assessed for their safety, quality or effectiveness. And until the evidence base improves, the NHS will not routinely fund them, and clinicians will rightly be cautious about prescribing. And that is why through the NIHR and NHS England, the government is investing over £9 million in clinical trials on cannabis-based medicines for drug-resistant epilepsy to strengthen the evidence and support consistent, safe decision-making. And we also know that around 30% of people with epilepsy have a learning disability, as my honourable friend, the member for Lichfield, spoke of, and that the risk of SUDEP is higher for those with a learning disability. The most recent Learning from Lives and Deaths report found that epilepsy was one of the most common underlying causes of death for people with a learning disability between 2021 and 2023. And this highlights how crucial it is that information and support for patients with epilepsy who have a learning disability is tailored to their individual needs. Yes, I will.
I thank the Minister for giving way and for delineating everything that the government is doing to support people with epilepsy. I was fortunate enough to secure an adjournment debate a couple of months back to talk about the Clive Tracy checklist. Our honourable friend, the member for Glasgow South West, said from the dispatch box that he expects every NHS trust to be following the Clive Tracy checklist. Just wonder if she'd be able to agree with him on that point and send that message that all trusts must be following that checklist.
thank him for that intervention, and I welcome the development of the Clive Tracy safety checklist. It is an important part of Clive's legacy, notwithstanding the comments he made also about his legacy being much wider than that also. But we would encourage commissioners and service providers to use the checklist and its accompanying guidance as a key tool when designing services for their local populations, and to make sure that the steps outlined in the checklist are followed whenever a patient experiences a significant change in their care. So it is something that we do hope is getting rolled out and is getting followed and used as well. At the national level, there are a number of programmes and tools supporting safer, more consistent epilepsy care. NICE guidance recommends that people with a learning disability have monitoring reviews at least annually, and information should be tailored and adapted, including ensuring access to specialist care and coordinated multidisciplinary support. And for young people transitioning into adult services, NICE is also clear that planning should begin early. And while NICE guidance is not mandatory, the Government expects commissioners and service providers to take it fully into account when making decisions on how best to meet the needs of their local communities. NHS England's Right Care programme has developed an epilepsy toolkit to support commissioners and clinicians to improve epilepsy care and reduce preventable deaths. And the toolkit makes structured risk assessment and risk reduction, including proactive conversations about SUDEP, a core part of its guidance, and it signposts practical resources such as the SUDEP and seizure safety checklist to support consistent risk communication in line with NICE guidance. And Health Education England, now part of NHS England, has also developed an epilepsy programme in collaboration with SUDEP Action, including evidence-based training modules delivered through the NHS England e-learning for healthcare platform, covering practical diagnosis and management, medication adherence and SUDEP risk factors. And alongside this, the government-supported frameworks, including the National Epilepsy Bundle of Care for Children and Young People, are helping to drive more equitable access to timely intervention and rehabilitation. In closing, Madam Deputy Speaker, I would like to thank my honourable friend, the member for Didcot and Wantage, for securing this very important debate. It's great to see it so well attended, and I would like to thank all honourable members who took part in the debate and interventions, the member for Bracknell and Strangford, Stroud, Lichfield and Southgate and Wood Green. You made a number of very important points, and if I need to follow up on any of those points with colleagues in other departments, I will definitely do so, or within my own department. I also want to thank those with lived experience of epilepsy, and to the families who've lost loved ones to SUDEP also, whose courage in speaking out continues to drive change through the work we do in this place. We will continue to work with partners across the health system to support people with epilepsy and to reduce the deaths ultimately from epilepsy. Thank you.